and we'll get to that in just a little bit. At the end, we're going to do 3 different scenarios, 2, possibly 3, and we'll have a little bit of setup time, maybe 2 minutes in between, so just be patient. And we're going to be changing microphones from people who are doing role play, so just be patient. I do want you to pay particular attention when we get to the role play, so because there's going to be a question and answer session, and we know what voluntold means, right? Yeah, so everybody's got to really pay attention and speak up and volunteer, please. This is really important. So it's March the 1st, very first day of the month. It seems like it comes around very quickly. How many more months do we have in this performance period? Yeah, March, April, May, June. So technically 4 full months. So we're going to talk about our performance to date, as we always do, on the big 4 metrics or measures, but we're not going to spend as much time on all the metric detail. We're going to spend more time on the tactics, because just looking at the data really doesn't mean anything if we don't understand the tactics and execute those consistently to change the measures, to change the metrics. So here's our scorecard, corporate objectives. As you can see, we're making some improvement in mortality, and this is overall for the enterprise. We're at our threshold. We still have some work to do in HCAHPS, patient experience, again for the enterprise, case mix adjusted length of stay, some opportunity, and then readmission, some opportunity. But if you look at the measures, the scores, where we are versus where we need to be for threshold or target, in a couple of areas we're not that far away, right? So it's not impossible, and we have 4 full months, 4 full months. So we can impact these measures. Here again is our metrics broken out by campus. I just want to say kudos to Bledsoe and the Children's Hospital. They're really performing well and improving their service excellence scores. Case mix adjusted length of stay, east and north, certainly improving and looks pretty good, but some opportunities, as we can see. Children's Hospitals metrics is a little bit different. They're really performing well in terms of physician practice, 3rd day available appointment, and the harm events. They were just recognized, and we're going to hear more about that recognition next month by an external organization. Sue Vaughn is going to report on that at next QOC. But there's some opportunities for patient flow in the ED. So we all have things to work on, right? We all have opportunities. So with that, I'm going to turn it over to Donna for readmissions.
So we don't have any new data around our CMA LOS, so length of stay. We don't have that data because accounting is still computing that for January. So we only have a readmissions report for you today. So what we're seeing, we continue to see that the PCMH navigators are doing a great job, and you're going to see some numbers around that about the number of primary care follow-up appointments that we have. We're continuing not to make progress around the discharges by 11. We're not abandoning that. We're still going to be watching that. We're actually creating a dashboard metric around that. We're still trying to make referrals for home health for all of our Medicare patients that are high risk, with the exception of primary joint, because those physicians want those patients to go to outpatient, so we've got those carved out. We are not making the progress we'd like to around the follow-up phone calls, and you'll see that in our metric this month. We also don't have the enhanced med management calls set up. That's going to start in April, and we met recently to set up the dialogue that will happen over the phone with those patients, so we'll have that all set to go in April. We're also adding a dashboard metric around the percent of discharges that happen within 2 hours of the order being written. We feel like that's really going to be a better metric for us than that discharge by 11, because it's going to spread the discharges out around the day. If we really try to push all the discharges before 11 o'clock, all that's going to happen is we're going to back up EMS. So we change our bottlenecks. So we really want to smooth it out throughout the day. So you'll see us starting to report on that as soon as the dashboards are set up. We're still working with Epic to get them done, and there's quite a build involved in the dashboards I'm looking for. We have already started giving BID alerts to Puckett EMS on the projected discharges and the time of day on those discharges, and that's already starting to help with the flow. So we make rounds, or Paul makes rounds with the case managers in the morning. We get a report from them at 8:30 about who we think is going to leave and what time. We send that to Puckett immediately so that they can start scheduling, and then we do that again at 1:30, and we get an update on that. So we're seeing some good progress around that. Then we do want to refine and automate the capture of data. Today, this is very manual. We're still working with Epic to get the automation around that. So Kathy Thurman is doing a very manual process, and really appreciate all the work she does around that and getting the files to me to review. So we have some good and bad news. The bad news is our readmission rate for the year is still in the red. It's at 10.2%. That's mostly driven by 2 months when we had some high readmission rates. The good news is this month looked really good, and you may recall last month also looked very good, and we were in the green. So we only had 52 readmissions out of a possible or eligible population of 608 patients. So that was an 8.6% readmission rate. So we looked so good on that that actually the state called Paul Smith earlier this week and asked if we'd do a presentation for THA in October. So we're very excited about that, and said that we really look better than any of the other hospitals in the state look on readmission. So we're proud of that. And that's a team effort. Everybody in this room is making that happen. So there's just the graph, and you'll see that blip around October because we don't have, that was our transition to Epic, so we don't have good data around that, so we just pull it out. So on our process metrics, again, looking at all the readmissions that had no nursing services. So there were 52 readmits, 19 of those patients had no nursing services ordered at discharge, and that's 37%. So that continues to be our great opportunity. Then of the patients that went home, there were 30 patients of those 52 that went home. 19 of those had no nursing services. Again, it really puts a spotlight on where the problem is. 63% are going home. When I looked at those records, a lot of those are our CHF patients, and there are COPD patients, there are pneumonia patients, and so there are some reasons why they may not be getting home health. The biggest one being that they may not qualify because they're not homebound, and that is a huge CMS requirement. However, you can probably make the case that for a couple of weeks they are still debilitated enough that they're homebound. So we really do need to be looking at that. Even to get nursing into the home with them for a couple of weeks, I think would make a difference for us. Then the follow-up calls to the patients, of those 30 that went home, only 2 had a follow-up call. We make an effort 3 different times during about a 48-hour period to try to call these patients and families. So it's not the effort's not being made, it's that they're not being found or they're not answering the phone. So only 7% of those patients had a call. Then readmitted patients DC'd to home who had a follow-up MD appointment. This is where we're getting great traction. So of those 30 patients that went home, 73 had a follow-up appointment. That doesn't mean that was all within 10 days, although I'm not actually tracking that. I do put it on the spreadsheet, but I don't do a percentage around it. But it is looking really good on those that have an appointment made within 10 days. It's very good. There were probably only 3 or 4 that I saw that still had a note that said follow up with your primary care physician, didn't have an appointment made, or made the appointment and it was 2 months after the fact. So we've still got some opportunity, but this looks really, really good. We're not tracking that discharges within 2 hours written order yet, but we are going to start tracking that one. So then we've changed how we've been presenting these graphs to you. So these were done as percentages, and it's really just a percentage of those that were readmitting, so we're just moving the numbers around. So we really, Mike and I talked about it and said, let's just show you the raw data. So in the skilled nursing facilities for this month of December, only 12 of the readmits came from nursing facilities, and we have a high number that go to nursing facilities, so that's actually pretty good. Although if you look at the trend line, there's been no change. We've not really made progress. So I'm going to share this with the skilled nursing facilities, even though they have congestive heart failure programs, COPD programs, fall programs. We want them to see it's not really making that great of an impact over time. Home with home health, this is statistically significant that when we send them home with no home health, they return. So we had 19 that came back. home with home health, that was also significantly, had significance, and 11 of those patients still returned. What that says to me is that we've got to say to the home health agencies, we really need you focused on these congestive heart failure programs and these pneumonia programs, and how can you get back in there more frequently, particularly in those first couple of weeks, do more intensive nursing visits with these patients to keep them from readmitting. And then inpatient rehab, they had 10 patients that readmitted, and they have a slight downward trend, although that's not significantly or significant either. So just statistically significant. So just keep that in mind. So we will be sharing this data with those folks. This is going to help us with our preferred partnerships too, because as I've told you before, I drill down into actually each facility that they go to. I just don't present that here. So I know which facilities are doing a better job than the other ones are. So our takeaways around this month were we have continued improvements with the follow-up on the MD appointments. We still need to be doing better on getting those home health referrals out for patients going home. And our opportunity is really identified with the CHF patients. CHF was the most frequent group of patients discharged home with no home health care, so we really need to get focused on that. And we had one CHF patient that it was actually documented in the record that they had a readmission because they could not afford their prescription medication, and that's why they readmitted. They were not on their medication. So we've got to do a better job on getting those referrals to our pharmacy that's within our four walls, so we can get them up, and we can also work if we need to with case management on finding affordable medications for them. So any questions? Okay.
All right, well, I have some good news to share on mortality. So first, I'd like to update our December data. It turns out that in the EPIC transition, we were missing some eligible patients in the denominator for November and December, and so when we added those back in, the numbers look better than we previously thought. And then moving on to January, more good news. So if we look across the board, acute MI, we're at national average, CHF, better than national average, COPD at national average, pneumonia, with rounding at national average. I think we're red because we're compared to fiscal year 17 data. Ischemic stroke, better than national average. So all 5 conditions right now, we are at or better than national average. And we are just slightly above goal for our combined total. So excited about this improvement. So in January, we started a new process that we're calling pre-review. So we're reviewing mortalities now concurrently with the coding team. And this has proven to be a more effective review process than waiting a month or more for a committee meeting to review these mortalities. And it prevents the need to rebill or change the diagnosis after the fact. So I'm no longer going to present specific diagnoses that we've changed because we're getting this right really the first go around going forward. And this has really allowed the quality team to partner with CDI and with coding to achieve the most accurate principal diagnosis on these high-risk cases. And is Kyra here? Hey, Kyra. I just really want to thank Kyra Brown for really being a champion of this new process and making it possible. So thanks to her, and also to Karen Feltner and her team in coding for really partnering with us in this new process. So going forward, we're going to continue this pre-review process. And then also we're going to continue education about hospice on day 1. And I'm excited to say that our official launch for our ED hospice consult pathway is actually today. We did a soft rollout last week. And this new process allows ED providers to consult hospice in the same way that they would consult other services. So in the emergency department only, there's no need to find a case manager to have paperwork filled out. There's one number 24/7. It should be as easy to consult hospice as to consult cardiology now. And I'm really happy to say that we've had great partnership from ED leadership and providers in this effort. So I am looking forward to see the benefits going forward from this new process. All right, thank you.
So we were going to get some pharmacy updates from Alan Broom, but he just texted me and he has a situation. So if he arrives, we'll circle back. And if he is not able to make this meeting, we'll cover this next month. Brooke?
Good afternoon. So today we have something a little special. We're going to really focus our time today on hourly rounding, and I'd like to invite Jan up to kind of give her expectations moving forward, and then I'll go through some of our information with you.
Thank you, Brooke. First of all, hourly rounding, is that a new concept? No, it's not. Novel idea. We're in a hospital, and we expect that we'd be rounded on just about every hour, right? We are. Okay.
To Copper Hill.
Whoa.
Head southwest.
Don't do that. We don't want to turn.
Right.
Don't anybody leave to go to Copper Hill right now. The only person, there's one person that's here from Murphy. She might go back that way. Don't do it yet, though. Okay, so I guess I just wanted to say, lift up the expectations and tell you that there are expectations, and they're not unreal because patients are in the hospital. If there's any physicians in the room, please don't take anything that I say up here really too seriously, but I will say this. Physicians, I think you can agree with me, physicians usually admit their patients to the hospital because they need nursing care, correct? Right. And that means not just once in the morning or once at the end of the shift, but it's pretty much every hour that they need that nursing care. Now, hourly rounding is a team sport. So that doesn't mean that it's just nursing that should be in there. And really, nursing is not, they're not the only people that are in the rooms. I've had some personal experience just recently, and I can tell you there are people in and out of the rooms just about every hour, every 30 minutes, if not more. So how do we make it effectively a team effort and where that we join everybody together to say, okay, we're doing hourly rounding. If I'm going to make this one up, if I'm the physical therapist and I come into the room and I talk with the patient, or even if I've walked the patient or whatever, I go back to the nurse and say, guess what? Hourly rounding. Do you have something that I sign or something that we keep up with this? Because I just did the hourly rounding. You can spend time now with your other patients or whatever. We've got to figure this out, guys. It's not that hard. It's really not that hard. Now, the other aspect that I want to speak to, and Brooke's probably going to address this in her PowerPoint, but I'll give an example. If you just go into a room and say, I'm doing hourly rounding, do the patients know what you're talking about? What do they think you're hourly rounding on? The air conditioning, or maybe the floor, or the plumbing? Or, you got to know. What are you hourly rounding on? What does that mean? So really, in those terms, you don't necessarily have to use those terms, but I am checking on you. It's the time that I come in and prepare them as they come in, as you admit the patient. Prepare them. Someone's going to be in here to check on you every hour. And then when you go in, that is the checkpoint to say, I'm here. And it all works together and it's all good. But we got to make sure our patients know what we're doing. Not that they're just, we know what we're doing, right? We know what we're doing. It's good. But let's make sure that they know what we're doing also. It's all for the game of patient safety and the name of patient safety, not game. But I think you're going to enjoy what you're going to see this morning. And I will say this. Have you ever heard anybody that's going to perform and they say, don't really watch the way I perform or don't listen to the way I sing, but listen to the words and the song? Okay, well, I'm going to put the disclaimer out there. Don't watch necessarily the performers, but get the message of what they're trying to say. And I think you'll take that home and it'll be good for all of us. So thank you all for your attention, and I'll turn it back to Brooke.
Thank you. So we're going to talk a little bit about our commitment to excellence for hourly rounding, and I'll be brief because I want to be able to give time for our wonderful actors and actresses to be able to perform today. So hourly rounding, I know that you've probably seen this before. I've talked about this many times to most of you, but it's very effective in so many different ways. A lot of the reasons why we do this is to really decrease our patients' anxiety, to manage their expectations. We also want to reduce call lights, of course, and I know that sometimes we think we're taking on another project, something more that we have to do every single hour, but you can make your hourly rounding include everything. And so when you're in there, you can really, if you spend your time in the most efficient way, you're really going to see a reduction in that call light use. It reduces falls. This is more than just for patient satisfaction. This is for patient safety. It is important that we are seeing our patients. I recently noticed that we've had some patients or patient families who have asked not to be hourly rounded on, and that's not acceptable. We need to be able to see and visualize our patient every hour. It doesn't mean we have to turn the light on. We don't wake our patient up if they're sleeping, but we need to check on them. It's a patient safety risk if we don't. And always, this is my favorite one, this gives us an opportunity to manage concerns at point of service using what method? What's our service recovery method? LEAD, thank you. And also increase patient family satisfaction. So this is evidence of improvement with hourly rounding. This is a national study. I'll be glad to send you this information if you need it, on the improvements of hourly rounding when it's done in an effective way. A 52% reduction in patient falls, 37% reduction in call light use, 14% decline in skin breakdowns, and 12% increase in patient satisfaction. So as you can see, although hourly rounding and our commitment to checking in on our patients and families every hour, it is so far outside of the patient experience scope. It's really focusing on patient safety. And we think about that 12% increase in patient satisfaction, that is across the board. That is in our responsiveness. That is in the way that we're talking about our medications and pain. That is that call light use and the environment. Rounding on our patients every hour can increase every single one of our HCAHPS data scores. Okay, so this is our current hourly rounding scores, and just a little refresher, CMS changed the verbiage on hourly rounding to that we're checking in on you every hour, which is important to know because that's the way we need to communicate why we're there every hour, because that's the way it's going to be asked on our surveys. We do a fantastic job at bedside shift report, and bedside shift report is difficult to involve the patient and family, to get that information exchange out. If we can do that well on bedside shift report, there is no reason we cannot be at 100% across the board on hourly rounding. It takes time, but we can do it. It's just making sure that we're doing it the correct way. So we only have 5 or 6 units that are even above that 75th percentile mark. So that red line, anything beneath that is unacceptable. We have to get it above, and we can do it, but it's going to take a team effort. Okay. So I want to kind of talk about what we're focusing on when it comes to hourly rounding. Sonia and her process improvement team have an hourly rounding focus group that they've been working on for several months. And so some things that we're looking at, and when you see our demonstrations today, start thinking, are we doing these things when you see our actors and actresses performing this? Are we checking on their pain? So this is super important. Of course, pain's important anyway, but in 2017, CMS took out pain questions. And in 2018, they added them back in. But this time it went from managing pain to communicating about pain. So every hour gives us an opportunity to talk to our patients and family members about their pain. So when we're calling them and surveying them and we ask about their pain, they're going to know that we talked to them because we did it every hour. Checking on their personal needs if they need to go to the restroom, that's really going to reduce falls. Positioning, thinking about skin breakdowns, making sure that they're comfortable in where they're sitting or laying down, and possessions, getting everything that they need within reach. This is the purpose of hourly rounding. This is, I don't think it should be super scripted, but we have certain things we have to talk about when we're in the patient room. We can't just walk in and say, hello, I'm here to check on you, and walk out. There's no meaning to that. We have to introduce ourselves, because if we're taking this just not on weighing on nursing, if this is going to be a team approach, they need to know who is in the room and what their purpose is. I'm Brooke. I'm not your nurse, but I'm here to hourly round on you, check in on you every hour. Sorry, let me change that. Explain why you're there. You're checking in on them. Update your communication board. That's important so they know who to call, that you can address their pain and things of that nature, addressing the 4 Ps that we just discussed. And something very important that we need to do every single time is assess the environment. This gives us the opportunity to help our housekeeping team to work as a team effort to keep our patient rooms and their bathrooms clean at all times. And perform scheduled tasks. If you know you have to administer medication, there's things you need to do in a patient room, that is the perfect opportunity. That's why I say this isn't just something we're adding on. This is something that can really be inclusive of a lot of things that we do anyway when we're in the room 2 or 3 times an hour. And then closing. As we're leaving the room, we need to make sure that we say, myself or a member of my team will be back to check on you every hour. And making sure we're using those words, checking in on you. And don't just take the responsibility to yourself. If you know a team member might be coming in to do hourly rounding for you, make sure you introduce that. So we're going to practice. So I need you to bear with us because we'll have to do some changes between. So I want to throw up a couple scenarios. If we can get to 3, we will. Mr. Alan Broom was our last one, so if he can be here today, we'll do 3. But if not, we're going to do 2. So I'm going to give you the scenario, and then after that, I'm going to ask that we can turn the projector off so that we can see what's going on up here. So if we can go ahead and get started. This is going to be our first scenario. 45-year-old Mr. Teddy Nelson has been here for 3 days. He was found wandering around in the parking garage of the hospital without a shirt or shoes. He was unable to speak coherently. He was taken to the emergency department to be evaluated. Mr. Teddy Nelson has been off his psychiatric medications for a week, according to his family. His medications were started back during his inpatient stay. He was admitted to 3,000 to be monitored. Mr. Nelson continues to be confused. If somebody could turn that projector off for a minute. Thank you.
I was looking for it.
Good morning, Mr. Nelson. I'm Linda, and I'll be your nurse today.
Who?
My name is Linda,
Oh.
and I'll be your nurse today.
What are you doing here?
I'm going to take care of you today.
Oh, okay.
Can I help you get back up in the bed and make you more
Well, I
comfortable?
was wanting my drink up there.
I'll get you some water. We'll get you some fresh water. How's that?
Sure.
Let's get you back up in the bed and make you comfortable.
I'm fine.
All right. My goodness gracious. All right. Has anyone talked to you about hourly rounding since you've been here?
No one's talked to me about anything.
Oh my goodness. Well, let's talk about hourly rounding for just a minute. What that means is that we're committed
Who are
to.
you?
My name is Linda, and I'll be your nurse today.
Do you know what happened to my dog?
Yes, he's at home and he's fine.
Okay.
He's fine. So we're going to try to keep you safe today and keep you in the bed a little bit. And we want you to call, and she's helping us to keep you safe.
Okay.
Okay, so she's going to help us keep you safe, and she's going to help call me when you need something, okay? So we're going to put your call light over here where we can reach it. Sort of. So it's within reach for you two in case you need anything. And are you finished with your tray, Mr. Nelson?
Yeah, it wasn't very good.
Okay, so let's get back up in the bed. And we're going to put the bed alarm on you, and we're going to put your side rails up, just so you don't fall, okay? We want to keep you safe today. I would normally be wearing gloves and wash my hands and all that, but we're going to take care of this. All right, and then we'll take the tray. All right, how are you doing, Mr. Nelson? Are you still okay?
I'm laying down too much.
Okay, well, let's get you fixed. There you go. All right, you might want to pull that rail up too.
Let me pull your rail up.
Okay, there you go. I'm just going to clean up in your room a
Where's
little
my
bit.
dog?
At home. He's at home. I'm going to clean up in here if that's okay. My goodness. All right. I'm going to write my name and number on the board over here so you can call me on the phone if you need me.
Okay.
Okay?
Where's my phone?
I'm going to get it for you. We'll get it close. Are you hurting anywhere right now? Are you having any pain?
Are you talking about this place? It's about a 10.
Are you hurting anywhere? Are you feeling any pain?
No.
No. Okay. That's very good. All right. We want to keep you comfortable here. All right. Now I'm going to try to talk to you again about hourly rounding and our commitment to you. Okay? We want to provide you good care. Oh, there you go. This is your phone too. That's your phone too. So we want to express to you that we're committed to keeping you safe and providing excellent care. So we're going to be coming in every hour checking on you. We're going to be asking about pain. make sure you're comfortable, offer you help to the restroom if you need it. And
Where is the restroom?
The restroom is right over there. Okay? We're going to make sure you have everything you need around you and make sure you're comfortable. All right?
Okay.
Yes, Mr. Nelson, is there anything I can do for you right now?
I'm good.
Okay. Well, I will be back in about an hour to check on you. It'll be myself or a member of our team, and we'll be in here every hour. Okay? All right.
Don't kick my bed. See ya.
If we could get the projector back on, please. Thank you. So let's take a minute while we're resetting up for our next one. Tell me some things that you think went well. Right. Explaining why we're there and that we're going to be checking in. What else?
You got to repeat it so folks hear what they're singing.
Okay. So something we did well is we explained why we were there and that we'd be checking in again in an hour. What else did we do well?
She covered the environment.
Yes, she made sure that the environment was clean, which is very important.
She covered the 4 Ps.
She did cover the 4 Ps. Yes, she made sure it has call light.
Answered his questions.
Yes, she answered his questions, absolutely.
Updated the whiteboard.
Yes, and that's important. We updated the whiteboard.
She did the closing.
Yes, she did the closing and explained she'd be back in or a member of her team. Do we see any opportunities for improvement?
Checking the temperature in the room.
Temperature in the room. Okay. Yes.
This doesn't have to do with the hourly rounds, but just to reiterate on our psych policy, the sitter should be always facing the patient.
That's my fault. The sitter should be facing the patient. That's correct. We'll keep that in mind.
Should not have clothes on under the yellow.
He wouldn't follow that policy. So I don't know why. Thank you for that. Yes.
And is there some way to reach out to the family, call the family, and tell them that the hourly rounding has occurred, because he's clearly not going to remember that any of this happened?
That's good insight. That maybe we need to reach out to the family and let them know that we're checking in hourly. That's something we need to think about. Good insight. Thank you, Donna. Any takeaways? Anything that you think you could take back and implement with your team? Do you think it's just a nursing approach? Do you feel like anybody, non-clinical and clinical, could do this? Yes. And that's the point that we're trying to make. This is not just going to be nursing. When we start thinking about no pass zones, and as we walk by a patient room, their call lights on, you might not be a nurse, but it's going to be an expectation that we are checking in on our patients. Are we ready for our next one? Okay. If Miss Medea would come up. 35-year-old Miss Medea was having dinner with her husband. Her husband noticed she was having trouble with her left hand and was exhibiting slurred speech and facial drooping. He acted fast and called EMS. Upon arrival to the emergency department, Miss Medea was immediately taken to CT. She was diagnosed with a right MCA CVA. She was admitted to Northwest 7. Can I get the projector off, please? Thank you.
I'm Lynn. I'm going to be your nurse today. How are you doing today?
Not so good.
Not so good.
No.
Tell me what happened.
Headache, can't see, don't feel good.
Okay. Well, we're here at Erlanger. We are committed to do excellent care for our patients, so we do thanks. So we do hourly rounding with our patients. And what that means is somebody, myself or my team, will be in to check on you hourly for your safety and for your care. Okay? Can I help you get up in the bed?
Yeah.
Okay. Has your left side, can you use your left side?
No.
Not at all?
No.
Okay. Can you help me, please? This is Trina. Trina's going to help me get you back up in the bed, okay? There we go. Good job. Way to go. Are you comfortable?
No.
What would you like us to do to make you comfortable? Do you need to be on your right side or your left side?
A massage?
A massage. Okay. Where would you like the massage at?
Everywhere?
Let me call about that. I'm going to put my name on the board.
I have blurry vision. I can't see that far.
Okay. Well, we can move the board closer to you. My name is Lynn, and your tech today will be Angie. She'll be in also to check on you. My extension is 1234. Are you having any pain right now? Mm-hmm. What's your pain on a scale of 1 to 10, 10 being the worst, 0, a 10? When's the last time you had pain medicine?
No clue.
Okay, well, I will check our record, our chart, and see when your pain medicine was, okay? We're going to act like this is the phone. So this is your phone, and you can dial 1234, and that will reach me immediately.
5, 6, 7, 8.
1234. 1, 2, 3, 4. Okay? Mm-hmm. Did you see that? Mm-hmm. Okay. So we're going to put this where you can reach it. This is your call light right here. If you press this button right here, this is the nurse. Just press it.
Is that you?
That's me. Okay. And that's how you'll get me, okay? So, we're going to, have you reached me yet?
Lynn?
That's it.
I have to potty.
Okay, we can get you up to potty. Trina, can you help me, please?
Lynn?
Yes, ma'am.
My pain's still there.
We're going to get you something for your pain, okay?
Do I push this when you're in the room?
No, you don't have to push that when I'm in the room. I'm right here. You can just talk to me.
Okay.
All right. So we pottied her. We're just going to straighten your room up a little bit. How's the temperature in the room?
Hot.
Okay, we can make that cooler. Cooler. If there's family in the room, I'll usually show them where the thermometer is so that they can adjust it themselves.
I don't have anybody with me.
Okay, well, we're going to be checking on you hourly,
Can
if
I go
not
to the
more.
bathroom?
You sure can.
By myself?
No, ma'am. We want you to call us.
I want some privacy.
Okay. Well, what we'll do is we'll get a bedside commode in here.
Oh.
So this way we can get you up to the bedside commode. We don't want you to get up by yourself because we don't want you to fall. Okay?
Okay.
I'm going to go check on your pain medicine. Is there anything else that I can get you?
I'm hungry.
You're hungry.
Mm-hmm.
Well, it's 11:30. Lunch should be coming anytime soon. Okay. If you don't have lunch shortly, you just call me and we'll check on it, okay?
With this?
With that.
Okay.
Right there. Is there anything else I can do for you except checking on your pain medicine and getting you your lunch?
Can you call my husband?
I sure can.
Tell him that he needs to come see me?
I can do that. I can call your husband. Is it okay if we tell him what's going on with you? Mm-hmm. Okay, we can do that. Anything else I can get you?
No.
Okay. Well, there'll be someone from myself or the team to come back and check on you, and I'll be back with your pain medicine. Thank you.
Thanks.
Don't pretend to potty your patients.
You had a bedpan. I
It's kind of full. So what went well? She was very patient with her, yes. Did you notice that it doesn't have to be very scripted? It really is by the patient and getting to know them and building that relationship. So you don't have to walk in there with the script. It's just important that you're asking the right questions when you're in the room. Did you see any opportunities for improvement? Okay. Everything that the patient needed was on the left side, which was the affected area. That's very true. Yep. What else? Huh. Oh, the dirty tray still there. Sorry, Jim. Trying to help you out on that one. Always making sure we're assessing the environment is very important. There's trash in the floor. Just so you know, these are experts in hourly rounding, but I asked them not to be completely perfect. So we had some opportunities to improvement to talk about. And Alan, did he not make it? I don't think. Alan's not here. Okay. Well, I really appreciate you interacting with us today, and I hope this was helpful as a good example of hourly rounding, and we're really pushing this education. We start today with what groups?
Second wave, 8 and 9.
Yep.
We're going through
So, yes.
I would just like to say that it has made a huge difference on North Wing 7. Our hourly rounding scores before we did this project were at 60.
We want you to repeat that. Thank you.
I'd just like to say the project went very well for North Wing 7. When we started the project, our hourly rounding scores were at 60. And as you can see today on the board, our hourly rounding scores are at 85.3. So it's made a huge difference.
Thank you all.
Okay, I just want to say thanks to everyone here. This is a little different. I hope everyone enjoyed it, and I hope we saw that it doesn't take perfection to make a difference, right? It doesn't have to be perfect every time. It doesn't have to be scripted. I think we've saw some really good examples of how very different people can come together in a room and listen and follow a standard methodology to make great strides and improvement. So I want to personally thank Brooke, Sonia's team, Tracy. Thank you guys so much. Ted, you were a great patient. Thank you for giving us that enjoyment today. So be thinking about what you can take forward, right? So now that we've seen this, how do we pay it forward? How do we think differently? I think Jan really inspired us by telling us that hourly rounding is not a new concept. But I'm here to tell you that from this day forward, when I round, when there's a call bell going off, I will be going in the room and I will be addressing whatever needs to be addressed. I may be coming to get you to say, I'm not your nurse. I can't do that for you. I certainly don't want to potty you. I can't, right? I can't lift you. I can't potty you. But if you're sliding out of the bed, I'm going to help get you back in bed, and I'm going to call someone to help. You know, if you need your call button or if you need something else, right, I'm going to try to do that for you because I can. I feel empowered to do that, and I feel like Jan has inspired and empowered all of us to do that. And so I would just encourage you to, as you're out and about, no matter your role, no matter your title, we're all here to serve our patients, primarily to serve our staff who take care of our patients secondarily. So let's remember that. And thank you for your time today. I appreciate your attention. Thank you. Thank you. Good job. Good job.